Welcome to the Belgian week here in the Hilton Hotel in Antwerp. Welcome on behalf of Gilead Sciences Belgium. The intent of this round of talks is that we're going to put some questions to three experts, experienced gastro-enterologists who make part of our panel. Questions like, how do we go about eliminating hepatitis C? How do we screen? Can small scale initiatives make a difference, make the difference maybe? And what would or what should be the role of the government? We have here from right to left, from my right to left, Dr. Stefan Bourgeois from ZNE, Stuivenberg Ziekenhuis in Antwerp. Dr. Luc Lasser from CHU, Centre Hospitalier Universitaire Bruckmann in Brussels, and Dr. Wim Verlinden from AZ Nicolaas in Sint-Niklaas, Oost-Vlaanderen. Dr. Bourgeois, there is an opening now to treating F0 to F1 patients, which means that all infected people basically are in for treatment. So screening, I think, becomes even more demanding. Are we ready for that?
Well, I think we can be ready for that, but it will be important to send out the message to all our colleagues and all other people implicated in health to ask them for screening. Before there was the excuse we can't screen because if we screen we cannot treat everybody. No, we don't have any excuses anymore. And on top of that, the cost was always an issue. Well, there was a very important reduction of the total cost of a treatment, so no more excuses to screen.
Okay. The ultimate goal is in fact to eliminate HCV infection and achieve a world without infected patients. How realistic is this ambition, Dr. Verlinden?
Well, I do believe it's really realistic. When we try to eliminate a virus, we usually work with micro-elimination. So the concept encompasses actually two things. On one hand, we want to subdivide our general population into several risk groups. For hepatitis C, for example, it's men who have sex with men, IV drug users, prisoners, commercial sex workers, refugees or immigrants, and baby boomers. So by dividing this population into those risk groups, we're allowed to tailor our approach, our screening, our cure towards that fits this small group. On the other hand, microelimination also means breaking down national and international guidelines to smaller goals to work locally in local circumstances and adjust your program to the local circumstances. So I do believe hepatitis C elimination is possible if you use microelimination.
And what's your experience with it in practice? I mean, what's the impact of it?
For me, for example, I work in a non-university hospital, and by doing these local projects, we're allowed to tackle our own community. And by doing small projects, you can really see the effect in the small community. But I think afterwards, if you add up all these local efforts and all these projects, you will reach those elimination goals.
Yeah. Is there also a role for screening in hospital settings, for instance, the emergency room?
It's a difficult question. Is general screening a good thing? I think we do screen a lot, and there has been projects that screen everybody, but the yield is not so high. It's not really cost effective. I think you should really focus on screening those risk groups. Mm-hmm.
In concrete terms, what can be the responsibility of both university and non-university hospitals in screening and in microelimination?
I think for now it's mostly university hospitals that are doing more projects because they're used to doing projects. But I think, especially now, like colleague Bourgeois said, because it's reimbursed for everybody, I think there's no reason not to screen anymore. And I think if everybody works in their own hospital and their own neighborhood, we will reach those goals. And I think everybody should do it. And I think it's really feasible now.
But it's also time-consuming.
It can be time-consuming. That's why it's a group effort, I believe. So I think you should involve your colleagues, your interns, assistants, social workers, for example. And you don't have to do everything at once. I mean, you can split, your projects over a larger time frame, and then eventually you will get there by not spending too much time on it.
Yeah, Dr. Bourgeois, you also have to apply a certain outreach approach, I think.
Well, it's not so easy for all risk groups to get into the hospital. So what we try to do is to do outreach, meaning that we go there where the patients are. And in my case, we work a lot with persons who use drugs, and those we have a very good system with the C-buddies. These are peers that go out to get those persons, to explain them that we will help them, that we can not only screen them but also treat them. And so that's a very important part of our job now. And it's feasible, it's really feasible, but you need some enthusiasm and you need to be a little streetwise.
You need a team. You also need the support of patients, of C-buddies. How does that work?
Well, C-buddies are peers. These are very nice people, are kind of volunteers that help those patients to get to us, not to be tackled in the reception, people that help them to make sure that their administration is okay, social security is okay. So, and they have some experience in being treated or to treat patients. And those people that are very, very harmless in our society, that need to be helped in our society, they are very good candidates for treatment. And some people think that they are not good candidates, but we have been proven that they are doing very, very well.
Mm-hmm. Now that all HCV patients can get treatment, can micro-elimination projects, Dr. Lasser, do the job and eliminate HCV, or is anything more maybe needed?
I think they are very useful, but without any help of authorities, it will be quite difficult, because we know in Belgium there are no very small initiatives from the authorities, and we know we are far behind, because there was an analysis from the Boston Consulting Group, and they show that Belgium is in the ranking on the same level than India, Mexico, so we are far behind. So and when you see countries behind us, that's like France and Netherlands, they are far before us. But
would it be an idea to propose a once-in-a-lifetime HCV test for everyone?
It can, yes, but at this moment it will not be efficient, because there is not enough general awareness in the general population with the general practitioners also. So most of the people have been screened more than once in their lifetime. So that's because when we see the number of serologies that are being done every year, it's about 700,000. So most of the people from the baby boom generation, we know that half of them have been screened already. But what have we done with the screening? So most of those people have been screened maybe once and then twice or twice. Let's say it's not well coordinated at this moment. So that's due to the general awareness of the general practitioners also. That there's a role of the authorities to sensitize the people, to sensitize the GPs. And that's what's lacking at this moment. So we are depending really on those small projects and micro projects. That's like I said, they are very useful, but it will not be enough, I think, to screen everybody and to eliminate in Belgium, because we want to eliminate before 2030. But I don't think it's feasible. Only with the small projects.
Dr. Verlinden, the awareness is an important issue as well. There is the fact that the results of the questionnaire directed towards MSMs, men having sex with men, was relatively poor.
Yeah, that was a project that we did. We tried to get the knowledge of hepatitis C in this community, these men who have sex with men, because it's been estimated that 1 in 4 of new infections will be in that community. So we include 300 people, and actually, for example, 30% didn't know it was a sexually transmittable disease, which is already a lot. And of those 70% that did know it, there was a lot of misconceptions. For example, half thought there was a vaccine, which is not. Half thought they would always have symptoms, which is also not the case. The majority didn't think there was a treatment. And if you would ask the different ways to get hepatitis C, most of them knew which practices were risky, but also the majority overestimated other practices as riskful. So I think there's really a gap of knowledge in that community that we should tackle, actually.
Yeah, there's also a stigma, Dr. Bourgeois. People are reluctant because of this stigma. How does this still work?
Well, hepatitis C is a blood-transmitted disease, but as Wim just told you, there's there are other factors how to get it, and people think that it's a sexual transmitted disease, and the stigma is especially that it is linked to drug use, to junkies, to a far not so well known part of our society.
It's like a bit of a dirty disease.
Yes, and that makes it difficult for some people to come out and to get tested and to go for treatment. And also there's a lot of misconception about the treatment by itself. People think that we need to do a liver biopsy, what is a painful procedure, they think, what is almost killing them, they think. That's not the case. The treatment is becoming very, very elegant. It's a short treatment, and it's a treatment with no side effects, with a very big chance of total eradication and cure. These are all things that people are not aware of, and there we think we have to battle that and tackle that stigma.
Okay, a question to any which one of you. What should be done then? I mean, how do we tackle this?
I think this is the role of the authorities, because we will not be able to inform everybody. So if you want to pass by all the, let's say, the information to the general population, then we have to go through general projects, and then we will be able to let's say give some information to local patient groups, general practitioners, but we will not be able to inform everybody. And then you need something organized. You need let's say a strategy, and then that is lacking in Belgium at this moment.
Are healthcare specialists
yes,
always sufficiently educated, sufficiently aware?
No, that's a problem, because if you want to screen patients, you have to know what patients you have to screen. You have to know what is the treatment at this moment. So a lot of GPs don't know what the treatment is, like Stefan said. So there are still many gaps in their knowledge, and we will not be able to fill them, because to tackle them, because we really need some let's say a general strategy.
So GPs should be sensitized.
Yes, of course. Yeah. I think very already should be sensitized. So that's the goal of let's say general authorities to let's say synthesize.
In order for them to do what?
Just to be aware that what is the disease, what is the treatment, that the treatment is really let's say efficient. There are no secondary effects. There's
referral.
Yes, referral. Yes, of course. That's really important.
If I may add something, I do believe that the government has an important role there, but I think we, as well as specialists in hospitals, often we have to go to local GP meetings, and we have to speak about updates in gastroenterology. I really do believe we have some power there to also just tell something about hepatitis C. It doesn't need to be a lot, just say which risk groups there are, how the treatment is, and I think by also from us synthesizing the GPs, just every 2 years maybe when you give a presentation, bring up the subject, and I think it will also add a lot of beneficial effects.
Yeah, efforts to unite gastro-enterologists and addiction specialists.
Yeah, we took the initiative there. There is a international network on that, and so together with Geert Robijs and some of his colleagues, now we build up a Belgian network for substance use and viral hepatitis that will kick off in the weeks to come. And
what is that?
It means that we want to go out to the addiction centers. They see the most of the patients. The prevalence is very high over there. 35, 40, 45% of those drug or ex-drug addicts do have hepatitis C. So if you can work together with the social workers, with the addiction specialists, with the peers, we can get more people, we can see more people. But I think there it's a micro-elimination, but for a general approach, we don't only have to look at other practitioners, but maybe we can sensitize also the population. In the United States, there are billboards saying get tested for Hep C. If we could have a small publicity 2 minutes before the news on television about hepatitis C, maybe we can ask the general population to go and see the general practitioner and say, you test me for cholesterol 3 times a year, maybe test me for Hep C too.
We can do all these things, but do we?
Well, there are elections in May, maybe. Maybe we can ask the people that are responsible, but the people we vote for, to take some action. There is a national hepatitis C plan, 22 points, but only 6 have been realized. So there is an enormous gap in awareness and screening, and we need official instances to help us through that.
And it's important because it costs human lives.
It's important. Not only it costs human lives, but that way by the lack of knowledge, by stigma, by a lack of awareness, people are infecting themselves over and over again. And there we have to make sure that we can stop this epidemic.
Yeah. I think it is the complexity of Belgium. So at this moment we have 9 ministers of public health. So, and now they're still for the national hepatitis C plan, still elaborating collaboration. So they are not coordinating anything. So not enough, of course. And that's everything is divided. The budget is divided. The responsibilities are divided. So that's the problem in Belgium. So there's no real coordination. There's no hierarchy in the different authorities. So everybody is working to everybody. So
but as specialists, as gastro-enterologists, do you undertake something? I mean, do you try to tell them what should be done?
Yeah, but it should be the other way around. So the authorities should help us, but it's not to us. But it's not the reason not to do anything. But I think it's the other way around. It should be. But,
so in fact, if I understand you well, screening for the time being is completely dependent upon local initiatives driven by people like you.
At this moment, yes.
And luckily, with the funding of the pharmaceutical industry, we don't get the funding from the government. We are lucky.
Yeah, because screening is costly, isn't it?
It takes time, it takes money, it takes energy. And we are very enthusiastic to put in a lot of energy in it. But we are lucky also to have the grants from the pharmaceutical industry to provide us with the tests and the logistics around micro-initiatives like we do now.
So, but for you, I mean, the lack of government support, if I may put it that way, it's not a reason to sit back and do nothing.
No, it's not. I think that's thanks to these projects and the grants we're allowed to do these the projects we are doing. It was asked for to explain the project. So, for example, in our a big project we did was loss to follow-up, for example, which is a very easy project to do everywhere, and it doesn't need government funding or anything. So what happened is at University Hospital of Antwerp, we looked at all the patient files of all patients that were ever followed at the hepatology department, and we saw how many of these were still in follow-up, and we could see that up to 30% was not. So they never showed up for their consultation. So by just reaching out to those patients, we were able to bring back a lot into follow-up. And again, we also, another part of the study, loss to follow-up, was we looked at positive hepatitis C serology requested by non-gastroenterologists. And also there we saw that 1 in 5 was never referred. Again, we reached out and we were able to bring back more than 50% of those patients. So this, for example, is an example of a study which is easily done, not so costly, but with a big yield. And I think we don't need to wait for government support only. I think we need government eventually to finish to really eliminate it. But I think these small projects, they should be done everywhere already.
How far do you get, you think, I mean, with just the micro-elimination projects compared to the final ambition of actually eliminating HCV?
I believe that the bulk of infections, the bulk of hepatitis C patients, you will treat through micro-elimination. I think all these projects, if they're done on a local level but everywhere, you will get the bulk. But I think those last patients, to really eradicate them, we will need government.
Okay, we are at the end of our... Yeah, excuse me?
We're very strong in focusing on these high-risk groups. The MSM, the drug addicts, the immigrants. There we can reach out, we know where they are, where we know the people who to contact. But as Wim says, those lost somewhere in small villages, there we need other means to really get through those people.
Is there any need for a broader national project, you think? I mean, of you as gastroenterologists, because micro is micro, and you could put the question, what's the coordination of the micros?
Well, I think what is very important is to make hepatitis C sexy.
How do you mean?
What I mean is cancer is very sexy. And don't misunderstand, what it means is that a lot of attention, a lot of budget goes to screening for cancer, which is very, very important.
Of course.
No discussion about that. But hepatitis C is a disease for drug addicts and junkies and people with strange habits and hobbies. So that is what we have to do, is to make sure that we can easily screen and very easily treat with a cure rate of 98, 99%. And that's very in contrast with cancer, for instance.
So we do have to get rid of that stigma.
Yeah.
Okay. I would like to thank you very much for coming and taking part in this discussion. We have come to the end of our round of talks. I would still like to add that there is more coming up from Gilead Sciences. We have soon a multidisciplinary debate on NASH, the next thing on the plate, particularly of hepatologists, amongst other initiatives, of course. See you there. Bye.